pointer is this one. Good morning, everyone. Good morning. Yeah. Good morning, everyone. I am not English native speaker, so my English is quite easy to understand. So I'll try not to go very fast and explain to you about the perspectives of the organ preservation in larynx and hypopharynx. The functions we want to preserve are the speech and the swallowing. So, Dr. Lin, someone will translate, or we will. No need.
Yeah, I guess that we can go through.
Yeah, sure. So after I will have, if you have questions, I'll be happy to answer too. So today I was giving the objective and the target to talk to you about how we can preserve the treatment of larynx and hypopharynx. It's a multimodality treatment. So it's been a long way, and it's like Dr. Mai will say in her presentation, it's very long presentation because it's for larynx and hypopharynx, we have a lot of trials and a lot of updated results. We have trials that are dedicated to larynx cancer and hypopharynx, and we have several milestones for the research about the preservation. So the organ preservation for early larynx cancer is a chapter on its side, because early larynx and hypopharynx is not the same as locally advanced. Then the voice swallowing functions, we need to standardize what we call functional larynx, because doctors are most of the time happy with themselves, right? When you do partial laryngectomy, you feel the patient is okay. And when I do radiotherapy, I feel the patient, is okay. But we need to know what is a functional larynx, what is a good swallowing. So we need to have scores that help us be objective and not only be happy with ourselves, because sometimes the perspective of the patient is not the perspective of the doctor. Most of the times we are happy about ourselves. So there are progress in techniques in larynx preservation techniques with the radiotherapy or with the surgery. And I know that today there are presentations about the improvements in surgery. So I will talk only about the improvements in radiotherapy, and the colleagues later this morning will talk about the laser endoscopic surgeries and the partial open larynx surgeries. So can post-operative radiotherapy safely complete partial laryngectomy? Because we will do more and more partial laryngectomies, right? But we will have sometimes upsetting pathology results, and we will have R1 resections. So it's a question when you start doing partial laryngectomies to know if your result in pathology is not as good as you thought it would be, then can you do post-operative radiotherapy? What are the milestones in the research of the preservation of locally advanced cancers? What we know, and we all know about the guidelines, but I would like you to know how we got to these guidelines of larynx preservation so that you can choose well your patients. Because if you look at the guidelines, you don't really understand how the results got there. And in order to apply them, you need to know about who were the patients that were successfully treated by preservation. The standards of care, how we got there, and any improvement in these standards of care. And then the T4s, are there an absolute counterindication for the preservation? And if not, who are the ones that are adapted? So for the early stage hypopharynx and laryngeal cancer, the data is less available than in the locally advanced cancers. We feel like these are the cancers we know the best, right? Vocal cords, small cancers. But the data actually is not as strong as it is for locally advanced cancers. It is mainly, there is less data. It is mainly based on retrospective series, and it is the functional results are very sparse. Because these patients, we don't follow up very well. We don't know if they have very good results or not. They are cured and we never see them again. So these are the classification you know very well about the glottic cancer. It's, by the way, a type of radiotherapy that very little radiotherapists do, because the classification are very complicated and the anatomy for contouring is very complex. So whenever a radiation oncologist is very good at treating breast cancer, cannot treat larynx or hypopharynx cancer because anatomy is so complex and the ways of dissemination of the disease, the way where the disease can go and how we contour is very different. So radiation oncologists that treat head and neck cancer are very few and very specialized. So the classification, of course, as you might know, surgeons and radiation oncologists, radiologists also know that the classification is different, whether the disease is supraglottic, glottic, or subglottic. But all in all, it is the same philosophy. But one thing is very important is the information about the mobility. And you as surgeons do the endoscopy and see if the cords are mobile or not, if the disease. But when we receive the endoscopy, we don't always have that information. And it is very important for us. So today it's an occasion for me to remind you, please inform us when you do the endoscopy about the mobility of the cords. Most of the time when patients come from UMC, we do find that information, but not all the time. So for hypopharynx, also, this is the classification. So these are the American guidelines for the larynx preservation. And the American guidelines are very, very surgery orientated. I'm sure that the ones that did the American guidelines are surgeons, because when you read them, it's very pushy for surgery. And still in T1 and T2 laryngeal cancer, they say that we need to treat them in a conservative way. Means we need to try to use either radiation or surgery in order to preserve the T1 or T2 cancers. So what are these strategies? They are other surgical strategies, and later presentation will talk about the endoscopic surgery and the partial open surgery of the larynx. And there are the non-surgical strategies, which are the radiotherapy alone or the radiochemotherapy. What we know is that we try to avoid the chemotherapy because it gives less good functional results. We try to do only radiotherapy because it gives better results. So both of these treatments used for T1 and T2, which are the partial surgery, endoscopic surgery, and radiotherapy, have done a lot of improvement. So the fight is still there and it's very strong. Radiotherapy improves, surgery improves, and both treatments are possible for the patient. So when we see the recommendation in the American guidelines, they say use endoscopic surgery because, and this will depend on the exposure of the tumor. But what is not acceptable is to have an endoscopic surgery, then do radiotherapy. It's not a good option because the functional results are not good. So whenever the exposure is not good, or whenever you think you will not be able to remove it all because of anterior commissure, or then at that time, radiotherapy is better. So we don't know what to do for T1, T2s. You know that the patients can be treated by both, but we don't know which one to use. You will choose according to the possibilities of surgery, but there is a trial that is ongoing now that will have a head-to-head comparison between the endoscopic surgery and the radiotherapy. And it's a phase 3 trial, randomized, ongoing now. But the results will be in a very long time because, you know, these patients are highly curative patients. They relapse a long time after, and the functional results stay good for a long time. So the results, the final result of this will be in a long time, not immediately. Meanwhile, we will still fight on these patients who will treat them radiotherapy or endoscopic surgery. So for the glottic and the transoral laser treatment, the data is really very good. And there is data that says that better functional outcome is with radiotherapy. And this is measured by the beta maximum phonation. And this is not because I'm a radiation oncologist. It's because there is a meta-analysis that has said that the radiotherapy may have a better choice. Why? Because these data are all not head-to-head phase 3 trial comparison. So they are frail data. We cannot really rely on them. And that's why we have the VOICE trial ongoing to really compare. So radiotherapy may be better choice for the glottic cancers with a better functional result. So this is how we have these guidelines from the ESMO for the T1 and T2. So now you know that for the larynx early stage, we can go to, this is the Pan-Asian adapted results. So we know from where they come. There is no solid phase 3 head-to-head comparison. It is mainly based on retrospective data, but the results are so good. That's why we did not do clinical trials, because both results are absolutely great. So now we will have clinical trials in the future, but meanwhile, there will be a good collaboration until we have the results from the VOICES phase 3 trial. We need to have a good communication, give the patient the right information, and collaborate together for the best of the patient. So now how can we standardize the results to say that radiotherapy is better, or you say endoscopic surgery is better? In order to have objective, we need to have questionnaires about how good is the voice, and we need to have questionnaires about how good is the swallowing. So the voices and the swallowing functions need to be evaluated by simple inventories. They need to be taken from a patient point of view, not from the doctor point of view. And we need to have a comparison between the arms of the trial and stop the indirect comparison between the retrospective data. So now we have seen the organ preservation from the early larynx cancer and the swallowing functions. So what are the progresses in technique for radiotherapy? So for the radiotherapy now in the glottic cancers or in the hypopharynx cancer tends to be very small fields. This is already IMRT. This is already modern radiotherapy. But after this modern radiotherapy, now we started, like for the laser, to irradiate only vocal cords. We don't irradiate the whole glotta anymore. We irradiate only the vocal cord, and like we mimic what you do in the endoscopic surgeries. So this gives much better results. And there are trials that have compared single vocal irradiation to the whole glottic irradiation, and it has excellent local control and better toxicity profile. So endoscopic surgery is improving, but also the radiotherapy is being very economic and improving a lot. So whenever we have patients like this, so we will irradiate only the zone of the tumor here, and we will take some margin for the microscopic extension around. This blue line is the margin we take for the swallowing during the radiotherapy treatment, because when the patient swallow during the radiotherapy treatment, that vocal cords will go up and down and anterior and posterior. So we account for that. We account for that margin up and down, right and left, but still the volume of the radiotherapy is very small. So the results of functionality after are really good. So for localized radiotherapy, we try to have conservative surgery or exclusive radiotherapy, and we try to avoid the concurrent chemotherapy, because adding chemotherapy adds off the fibrosis and edema and side effects. So we only keep it for big lesions. So how we can select the patient for the partial laryngectomy or radiotherapy, it depends on how you think optimal will be your surgery, the R0s, and we select them on the respiratory functions also. But if the partial surgery is incomplete, can we do post-operative radiotherapy? This is a question I would like to answer, because back in France, maybe 10 or 12 years ago, a lot of partial surgeries started, every center was doing, and we started to have little percentage of patients that was in incomplete resection after partial surgery. And we were very annoyed because we did not want to alter the functional result. Because if you have already a larynx that is partly removed, so how can you, if you do radiotherapy, maybe the result will not be good. So we have now data from these patients that we have irradiated in the past. So this is a 2023 result of a meta-analysis of all these patients that were in the past irradiated after partial radiotherapy. And it seems that it is safe to do the post-operative radiotherapy for the open partial laryngectomies if we face adverse post-operative features in the pathology. And with that, we can increase without an increase in toxicity and without affecting the neolarynx. So if you have any patient you thought was very good candidate for open partial surgery for the larynx, but after that, unfortunately, the pathologist says maybe in that zone there is in situ disease, or there is a margin that is very close, then you can send the patient for post-operative radiotherapy, and most likely with expert teams, you will not have the functional result altered. So now we will go to the locally advanced larynx and hypopharynx. In locally advanced larynx and hypopharynx, where the treatment is laryngectomy, we have a lot of randomized trials. And these randomized trials are specifically dedicated to larynx and hypopharynx. We have a lot of mature data because it was very important for the patient's quality of life to preserve the voice, to preserve the swallowing. And that's why the trials have started. And so I went fast on the classification because I think for radiation oncologists it's important, but for surgeons, I think you know it very, very well. So there are a lot of trials starting with the historical veteran study, but RTOG trials, meta-analysis of all these trials, and we have the GORTEC and EORTC trampoline trial. So a lot of dedicated trials for the larynx. So these trials have been the countries that have participated into the trials that gave, for example, the NCCN guidelines are from all over the world, very little from Asia. But I think that for larynx and hypopharynx cancer, there is not a big difference in the disease. You know, when I came to Vietnam, I found that the oral cavity disease is completely different in Asia than in Europe. My patients with oral cancer are different from my patient. Esophageal cancer is very different in Asia from patients I used to see in Europe. But the larynx and hypopharynx are pretty much the same. I don't see a big difference. They are alcohol and tobacco-induced, less HPV impact on larynx, and the patient status is also almost the same. They are heavy drinkers and smokers. So all in all, we can rely on data from all around the world to extrapolate to our Asian patients. So the first laryngeal preservation trial was the veteran trial. It was an old trial. Who says old trial says also old radiotherapy, right? So we need to keep in mind that the results of the veteran trial is a trial that showed us that we can preserve the larynx for patients, that compared to laryngectomy, it did not affect the survival. So the standard surgery for the veteran trial was the total laryngectomy, and we receive induction chemotherapy with cisplatin cisplatin and 5-FU, and we consider the patient a good responder when the patient has shrinkage of 50% of the size of the disease. So we see that it did not affect the survival. It has shown that we can preserve the larynx safely, that we can use neoadjuvant chemotherapy, and the trials are function-centered and no impact in survival. So you see the veteran trial started in 1984 and no impact in survival. But also the GORTEC trial, which was the one we use now, it's not historical. The GORTEC trial is one trial that was done in 2000 and still no impact on survival. So in larynx and hypopharynx, we did a lot of improvement to let the patient live with larynx and to swallow for the hypopharynx, but still we did not change the survival of patients compared to laryngectomy. So there is a lot of work to be done to improve the survival. Till today, we only improve the function. We don't improve the survival. So after the veteran trial that has shown that we can do neoadjuvant chemotherapy, there was a whole trend in radiotherapy to show that radiotherapy alone was less effective than radiochemotherapy. These trials and this meta-analysis are not only for larynx cancer. They all for all the squamous cell in the head and neck region. And we know that the squamous cell in the head and neck region is almost the same disease. The zone is different, except from the nasopharynx, that it is another story. All the other ones are squamous cell due to tobacco or HPV. So we know that from these meta-analyses and from several trials for head and neck in general, that if we use chemotherapy with radiotherapy, then we do better. So after that, we know that the RTOG trial, now that we know that radiochemotherapy is better, came the RTOG trial, which is a trial that is quite old now and has compared the standard of care radiotherapy to radiochemotherapy, which is the new trend in the head and neck, and compared to the veteran arm, which is neoadjuvant induction chemo than radiotherapy. So we see that the radiotherapy alone is the loser arm. So we will not do radiotherapy alone for locally advanced larynx. It's almost for us. I mean, it's not very bad, but it's bad compared to all the others. So we will do radiotherapy alone only when we are obliged. Now the question is, we do induction chemo or radio and concurrent chemotherapy. This is laryngeal preservation. So the laryngeal preservation was higher with for the radiochemotherapy. But whenever we take the chemotherapies with the PF, we have a meta-analysis. We have that we can preserve the larynx in more than 50% of the cases, and we have patients that have survival for 45%. So the induction chemotherapy benefit in the RTOG, so this is the RTOG trial. So this is radiochemotherapy, this is induction chemotherapy and radiotherapy. One thing is important is that the RTOG trial is not interpreted in the same way in Europe like in America. In America, for them, the RTOG trial has shown the superiority of radiochemotherapy. In Europe, they say that the RTOG trial has shown that induction chemotherapy and radiotherapy is better, because they think that here we have higher patient alive with larynx, we have secondary laryngectomy, but patients are alive, and we have more patients that are alive with a functional larynx. When we see the radiochemotherapy here, we have less patients that are alive with larynx, and they have a very big number of patients that die not of cancer. You see, patients that die here are very, very high in the radiochemotherapy. And most likely what is explained is that these patients die from inhalation pneumonia, they die from side effects from the radiochemotherapy sequelae, because the functional result with induction chemotherapy is better. So that's why when you read a paper of RTOG, it's not interpreted in the same way. When you see this chart, you feel like induction chemo is better. When you look at these ones, you feel that maybe radiochemotherapy is better, right? Here and here. So it depends on what you want. If you want the patient to live with the functional larynx, then it's induction chemotherapy. If you want the patient to die from other reasons, not cancer, but from pneumonia, then it's radiochemotherapy. So the interpretation is very, very not clear. So the RTOG trial interpretation is radiochemotherapy preferred. The same RTOG trial interpreted in Europe, they will say induction chemo and radiotherapy is better. So the RTOG trial and the veteran trial have used the induction chemo with 5-FU and platinum, right? But is it the best chemotherapy? So I will not detail this because I think Dr. Mai will do it in her presentation, but we know from very quick, some trials like the TAX 324 and T23 have shown that if we add the taxanes, then we have better results. So that's why another trial from my classmate, Johan Pointreau, he did another trial less known than the tax ones that compared the TPF to PF, and we had higher rates of preservation with very significant results. So from that time, we know now from the veteran trial that the preservation is possible. And the induction chemo can help preserve. We know from the RTOG trial that the radiochemotherapy is a very effective treatment. We know from the TAX 232, 234, and the Delosi 1 trial, which is a German trial, that the taxanes are better. So what will be the experimental arm after the RTOG? So the experimental arm will for sure use taxanes because we have this information, and then it will for sure use induction therapy and the good selection of patients from the veteran trial, and it will try to use radiochemotherapy after induction. So here comes my classmate, Johan Pointreau, and how he designed with the GORTEC trial. So GORTEC is Groupe d'Oncologie Radiothérapique de la Tête et Cou. So it's the head and neck group of radiation oncologists in France. So Belgium and Switzerland, French-speaking countries. So they have taken the induction with the TPF or TCF for cisplatin versus PF versus salvage laryngectomy. And for those who are good responders, they will have the radiotherapy. For those who were operated, they will also get the radiotherapy. Very important. We're not comparing laryngectomy to induction. We're comparing induction radiotherapy to laryngectomy radiotherapy. So this is the trial. It has been also updated 10 years after. So we have very long updates, mature data. So TPF compared to PF in good responders, they will have the preservation. And you can see here that after the TPF and after the PF, a number of patients has received chemoradiation and a number of patients has received radiotherapy alone. For now, we tend to give more chemoradiation than radiotherapy alone, but radiotherapy alone is the design of the trial. So the chemotherapy induction is PF and it's 5 days. The TPF and it's 5 days, and we need to give 3 cycles. So if, like me, you face the financial burden of 5 days of 5-FU infusions, of course, you can give capecitabine oral, but we need to know that there is a very good German trial that has tried the paclitaxel cisplatin for the preservation, and it is a good trial. That means if you have a patient for whom you want to omit the 5-FU for the induction, then you can. And you have data from trials that say that it is very acceptable to do paclitaxel cisplatin instead of paclitaxel cisplatin 5-FU, because 5-FU means 5 days of infusion and a porthacat. So in order also to extrapolate the data from GORTEC, we need to see what are the patient characteristics. You see very little females. So we don't really know how good they go through TPF, and we see that they were all in a very good shape. So if you have a patient that already lost a lot of weight and this already performance status 2, you need to hesitate before doing TPF. It really can be very toxic. So the compliance of the TPS was very surprisingly better than the PF, and it had a better response, and it has the rate of remobilization of the larynx was much higher. So we know that it is safe to do the TPF with experienced teams. Because, you know, when patients are in clinical trials, we pay really attention to them. And that's why the TPF was better than the PF. This is surprising. Normally, TPF should be worse tolerance, but it was better compliance. 90% finished the 3 TPF, only 80% finished the PF, but because they had special attention. So TPF should not be taken lightly. So in UMC, you are lucky enough to have a good team of medical oncologists to do TPF, but it's not an easy chemotherapy that you can do in any around the corner clinic. So we have the results of the TPF compared to PF. They are very good. And like we said, it did not improve survival. All the clinical trials for preservation, they did not increase the survival compared to laryngectomy. Only the functional result was improved. Very important. So the TPF is superior to PF. The rate of preservation is quite high. At 5 years, 74, 3/4 of the patients have their larynx. And at 10 years, after 10 years, still this result is maintained. So the rate of preservation is high and it is maintained over time because we are lucky for larynx and hypopharynx to have randomized trials, but mature data. 10 years after, those who succeed to preserve their larynx still keep their larynx. So now we go to what are the messages we can take from the RTOG. So from the RTOG, we know that the radiotherapy alone is a loser. So try to avoid it. The second one is that the PF followed by radiotherapy can have less good results in larynx preservation if the patient is frail and cannot have taxanes, right? We have these patients. PF, and if the PF will hold your patient from having concurrent cisplatin, means the patient is frail, cannot have taxanes. So you say, let me go for the PF. But if the patient, you think that if you have PF, you will not be able to do radiochemotherapy, then it's better to go directly for radiochemotherapy for these patients. Frail patients, if they cannot have a proper induction chemotherapy with TPF or with taxane and cisplatin because they have poor kidney function or they are in denutrition or they have the neurotoxicity from alcohol drinking. So if you cannot do a proper induction, then go for radiochemotherapy. It's better. This is what the RTOG trial shows us. If you do a bad induction with PF, then the results are less good. What are the home messages from the GORTEC? So the TPF regimen is better than PF, and we know that PF is better than radiochemo. So try to do a proper TPF for the patient. Radiochemotherapy after TPF is possible, and we try to do it as much as possible. In experienced centers, TPF is well tolerated, even if it is quite toxic. We have higher responses, higher rates of preservation, and higher rates of functional larynx when we use TPF and radiotherapy. The results are maintained after 10 years, and who is the one that will go for radiotherapy after TPF? It's a patient that after 3 cycles has more than 50% of response, remobilization of the larynx, or almost complete responders. So the integration of the targeted therapies, I will not talk about. I will leave it to Dr. Mai about the use of targeted therapies. So now you know how we came to these guidelines for the hypopharynx and the larynx locally advanced, how we can use either concomitant radiochemotherapy or induction chemotherapy. We know that the induction chemotherapy should be TPF or taxane cisplatin if a good induction cannot be done, then it's better to go directly to radiochemotherapy. These are the pan-Asian adaptation for the larynx cancer, and we see that still for the locally advanced, the induction chemotherapy is tried in patients that have indication of radiochemotherapy. This is what we use on current basis in our practice. So if patients are T3s and T4 that are suitable for LT, then these patients will be candidate for the laryngeal preservation. We will do induction chemo. If good response and larynx remobilization, we will do radiotherapy or radiochemotherapy. If they do not respond well, or if they relapse after the radiotherapy, then they will go for the laryngectomy. So quick questions about quick selection of patients. You know, some patients, head and neck surgeons have patients that are borderline already for laryngectomy, and they are afraid that if the patient progresses under chemotherapy, they will not be able to do the laryngectomy properly. So there is a trial from the German group that wasn't wired to answer the question about the induction, but in this trial, they have evaluated the patients after one cycle. And if the response is more than 30%, then they continue the laryngeal preservation. If we don't wait for 3 cycles, after 1 cycle, you already know. And this randomized trial has shown that you can evaluate the response of your patient after only 1 cycle. Another one is a Spanish trial that has shown that the quick selection of patients. So they do the same thing. The good responders after 1 cycle, after a single cycle induction chemotherapy, you can start the radiochemotherapy if the patient is good responder. If he is a bad responder, then at that time, better get him to the laryngectomy. So whenever you have a patient that has almost the indication of laryngectomy is already borderline, and you think that if we wait a little more and patient is not responder, maybe he will not be able to have the laryngectomy at all, then at that time, 1 cycle is enough. And you get along with your medical oncologist and tell him, you know, this patient, if progress, maybe will have permeation and will not be able to treat him well. So please do only 1 cycle. If the patient responds well, then we continue the induction. If the response is bad, less than 30%, then you can stop there. So these are data that are published. But what we need to know is that this neoadjuvant chemotherapy works only for larynx and hypopharynx. In other head and neck cancers, it did not show impact. In oral cavity, base of the tongue, the neoadjuvant chemotherapy did not do as well as it did in larynx. So here, we see that impacts of neoadjuvant chemotherapy, when we include all the head and neck cancers, still the only primary cancer that benefits from neoadjuvant is still the larynx and hypopharynx. We cannot extrapolate the data to the base of the tongue, to the oral cavity results. It's not as evident as it is in larynx cancer. So now, what is the role of laryngectomy in the era of oral preservation? So we see that here the patients in all the clinical trials we have talked about have included a small percentage of T4s, 10% of them. Mainly they were T3s, but little T2s, mainly because of the nodes, and a little percentage of T4s. So T4s were removed from the clinical trials because in the veteran trial, we saw that all T4s had failure. So the subsequent trials stopped including the patient with cartilage invasion because the first trial has shown that T4s were not good. So all the trials, the GORTEC trial, the RTOG trial, did not include patients with cartilage invasion. So there are patients that are inappropriate for the organ preservation. They are the deep invasion in muscles. They are the big T3s with poor swallowing, with destruction of the vallecule sometimes, and with the T4s with extra laryngeal extension through the the thyroid cartilage, and the patient that have poor laryngeal function. Sometimes the larynx is destroyed. You cannot clean it. I mean, the cartilage is very destroyed, or, if you do radiotherapy, the patient will not be able to speak and will not be able to swallow properly because the tissue is completely destroyed. So these patients are not good candidates, and they would better go with laryngectomy. So patients that are inappropriate for the preservation are patients that present tumor factors that make them inappropriate, T4s, extensive T3s, poor laryngeal and swallowing function, but also patients that are factors that are related to patient. Patient that counter-indicated for good chemotherapy, you cannot really do, and big disease. So either you do radiochemotherapy, you have poor renal function, you cannot do cisplatin, they have neurotoxicity, cardiac failure. So these ones, you cannot do radiochemotherapy, you cannot do the good induction, so they are not good candidates. And the patient that cannot follow up properly, because sometimes patients, if they do preservation, we need to follow them up, because if they relapse, we need to operate them. But if we cannot follow properly, maybe these patients are better go with the laryngectomy. So few selected T4 patients can go for preservation. They are the patient with very little cartilage invasion here, and the tumor size is still acceptable, and the airway is still acceptable. Some of these patients, we can preserve them. So that's all.